my pleasure to talk to you about the ABC in growth hormone therapy, algorithms, best practice, and controversies. I will touch on the differential diagnosis of short stature, algorithms for growth disorders, hormone therapy, best practice in growth hormone therapy, controversies in diagnosis and treatment, recommendations and guidelines. So it will be ABC of growth hormone therapy, the basics, and in the same time, A for algorithms and approved indications, B for best practice, and C for controversies which we encounter in our practice for every short child. So this is a common scene in our clinics. We get worried parents coming to us telling us, my child is the shortest in class. The basal growth hormone levels of my child are very low. ساعات بيقولنا كده بجروث هرمون معمول basal level ويبقوا قلقانين جدا ويسألونا is my child's endogenous growth hormone working? Any more tests? هل ممكن ابني ياخد حقن هرمون النمو؟ Can growth hormone injections make my child taller? I want to rejoin the sports team. ده لو جالنا طفل depressed وقلقان جدا انه قصير وطردوه من فريق الرياضة في النادي ويبتدي يكتئب ويحصل له تنمر ويجي يطلب بنفسه ويقول I want to take growth hormone injections to get taller. وده الكلينيشن اللي بيدخل عليه هذا الطفل في العيادة وبيسأل نفسه is this child really short, and if short هل هو normal variant ولا pathological ولا genetic ولا chromosomal ولا nutritional ولا chronic illness ولا psychological ولا skeletal ولا endocrinal. أسباب كثيرة جدا جدا مطالب إن هو يوصل للproper diagnosis. So this is the differential diagnosis of short stature. The most common is the normal variant, familial short stature or constitutional delay of growth in puberty or idiopathic short stature. Then comes the non-endocrine causes, chronic disease, malnutrition, dysmorphic syndromes, intrauterine growth retardation, skeletal dysplasias, and then comes the endocrine causes, growth hormone deficiency, resistance, hypothyroidism, Cushing syndrome, parathyroid, vitamin D disorder. So many causes. The most common is the normal variants. The next common is the non-endocrine, and then comes the endocrine causes. Most of these etiologies respond to growth hormone therapy. All of these which are in the red boxes. So, what are the algorithms for growth disorders? First, we look to the child. If there is no dysmorphism or no disproportion, or if the child has dysmorphic features or the child has disproportionate short stature. If there is no dysmorphism or no disproportion, we will exclude normal variants first, then chronic diseases, then malnutrition, then intrauterine growth retardation, drugs, psychological issues. If dysmorphic, we will do chromosomal analysis. If positive, may denote Turner syndrome or Down syndrome. If negative, other chromosomal aberrations like Noonan syndrome and Russell-Silver syndrome. If the patient is disproportionate, he can have skeletal dysplasia or inborn error of metabolism. So this is the algorithm that we usually go through in order to reach the proper diagnosis of short stature. What are the approved indications of growth hormone therapy? All these indications on the slide from 1985, the pediatric growth hormone deficiency, the adult growth hormone deficiency, the growth hormone in the transition period, so growth hormone deficiency in all ages. Second, chronic diseases, chronic renal insufficiency, AIDS, short bowel syndrome. All of these are approved. Dysmorphic syndromes, those in the pink, Turner, Prader-Willi, SHOX gene haploinsufficiency, Noonan syndrome. Prenatal causes like a child who is born small for gestational age with no catch-up growth, and then idiopathic short stature, even if the patient fits all the criteria, but the growth hormone levels are normal, can still respond to growth hormone therapy. And of course, the doses differ according to the etiology, as you see here on the slides. So what's the best practice in growth hormone therapy? Yes, growth hormone is needed throughout life. It's not only important for linear growth, but also it's important for the appropriate bone mass, better fracture healing, physical and mental energy, increased muscle strength, appropriate body composition, reduce cardiovascular risk. And then we want to have a bon voyage for children receiving growth hormone therapy. Our mission when we prescribe growth hormone therapy is to improve the journey for the patients needing this drug. We hope for our passengers receiving growth hormone therapy, high quality, comfortable trip on the business class, improve general and height-specific quality of life in children with short stature. And this is approved by the studies. It really increases the quality and improves the quality of life. Second, we hope for our passengers receiving growth hormone therapy, safe trip with no mishap. We don't want any side effects for these patients. We want to ensure safety for our patients and monitoring of the safety. We want to give technology and media devices for the comfortable, easy flight. So we want to use a device with comfortable injection settings and ease of administration. We hope for our passengers, satisfaction and adherence to the airlines. This is very important to ensure adherence to growth hormone therapy with a less cost. We hope for our passengers an easy, smooth transit connection flight. We want appropriate management during the transition period. So sometimes we do not stop growth hormone therapy even after completion of the final height. We continue in the transition period for the other beneficial effects, metabolic effects of growth hormone therapy. We hope for our passengers safe landing. So we want a safe transition and to reach final adult height in a better way. And if we look with one eye to the studies that were done on Omnitrope, we found that Omnitrope, a biosimilar approved by the European Medicine Agency in 2006, that Omnitrope has been approved in all the indications that we have mentioned before: the growth hormone deficiency, the Turner syndrome, the chronic renal insufficiency, the small for gestational age, the Prader-Willi syndrome, the idiopathic short stature. And after 4 years of treatment, Omnitrope resulted in improvement of growth parameters across all indications, irrespective of the gender or the pre-treatment status. And here is a study, a 2-year data from a long-term phase 4 study of recombinant human growth hormone Omnitrope in short children born small for gestational age. And this is the PATRO children study, a multi-center, non-interventional study of the safety and effectiveness of Omnitrope treatment in children with an update in the United States cohort. And these are the conclusions. Omnitrope appears to be well tolerated and effective in the majority of the patients without evidence of an increased risk of developing unexpected adverse events, diabetes mellitus, or new malignancies during the treatment. The height standard deviation score improvement, the delta H height SDS +1 from the baseline at 3 years for all indications. So what about the controversies that we meet in the diagnosis and the treatment of short children with growth hormone? This is Shakespeare, who is asking 2 questions. To test or not to test for growth hormone, this is one question. To treat or not to treat with growth hormone, this is another question. And one may ask this question: let us test every short child and see who has growth hormone deficiency. No, we cannot test for every short child, we cannot do the growth hormone stimulation tests because 2 growth hormone stimulation tests are needed to document growth hormone deficiency. And these tests are not without risks. Hypotension can occur with clonidine, hypoglycemia can occur with insulin, and of course these tests are also expensive, and if inappropriately done may lead to wrong diagnosis and then wrong therapy. So we have always to balance the risk versus the benefits, because exposure to potential adverse effect of growth hormone tests, if not done properly or if it is overdone, with exposure to potential adverse effects of growth hormone therapy, and there will be wasted expenses of the growth hormone stimulation tests. And if the growth hormone testing is not done, we may get a short child with no therapy at the end. So we should always keep the balance and only ask for the growth hormone stimulation test for the appropriate child. So growth hormone testing is done if growth hormone deficiency is suspected, which can be congenital or acquired, organic or idiopathic, isolated or part of multiple pituitary hormone deficiencies. These are the specific features of growth hormone deficiency, but actually we may encounter in most cases growth hormone deficient patients just a short child with no such specific features. We should always remember the neonatal presentation of panhypopituitarism if the infant presents with neonatal jaundice, cleft lip and palate, hypoglycemia, micropenis, undescended testis. So indications of growth hormone testing should be in cases of severe short stature, moderate short stature with decreased growth velocity, infancy, organic, acquired causes if there is marked decrease of growth velocity, signs of increased intracranial tension, signs of multiple pituitary hormone deficiencies, neonatal symptoms, signs of growth hormone deficiency. So this is a case scenario. Ahmed suspected to have growth hormone deficiency. As you see here on the slide and on the growth chart, Ahmed has a height below -3 standard deviation score, or below the 3rd percentile if you're using the percentile curves. And if we just project his height, we will find that he's away from the mid-parental height. Being away from the mid-parental height by 8.2 centimeter or by 1.6 standard deviation score, this excludes familial short stature. Actually, Ahmed is away by 13 centimeters from the mid-parental height. His growth velocity is below 4 centimeter per year, actually 3 centimeter per year. And he is crossing 2 centile curves. So Ahmed is meeting all the criteria of growth failure. If we suspect a case for growth hormone deficiency, we do the thyroid profile, we do 2 provocative growth hormone stimulation tests, IGF-1, IGF-1 binding protein 3, and then we do imaging of the pituitary MRI to exclude any structural defects or any organic cause of growth hormone deficiency. Of course, there are many debates around the growth hormone stimulation test, priming or no priming. Obesity reduces the peak of the growth hormone stimulation test. Growth hormone stimulation test may fail to diagnose growth hormone urosecretory dysfunction. Measurement of spontaneous growth hormone secretion has low sensitivity and specificity. There is also many controversies related to the growth hormone stimulation test with variable specificity, sensitivity, variability. Even the IGF-1 and the IGF-1 proteins, binding protein 3, are liable to many variations according to the presence of chronic disease, hypothyroidism, renal failure, or any other abnormalities. So we cannot depend on one test for the diagnosis of growth failure. The diagnosis of growth failure is multifaceted. Anthropometry, puberty, history, examination, biochemical assessment, radiological assessment. We put it all together and then we diagnose that this case has growth hormone deficiency or this case may benefit from growth hormone therapy. So here is Ahmed, 6 years old, has short stature, height below the 3rd percentile, The mid-parental height on the mean. The bone age is delayed 3 years at chronological age 6 years. The baseline investigations are normal. Thyroid adrenal profile are normal. Growth hormone stimulation test by 2 tests show low levels, 3 nanogram per deciliter, low IGF-1, low IGF binding protein, MRI is normal. As you see here, this is a classic case with documented growth hormone deficiency. So Adel is 5 years old. He has decreasing growth velocity in the previous year. His mid-parental height on the median. He has past history of brain tumor and cranial irradiation. The baseline investigations are normal. Thyroid and adrenal profile are normal. So test your knowledge. 1 growth hormone stimulation test is required to diagnose growth hormone deficiency, or here 2 growth hormone tests are required, or no growth hormone testing is required, and we just give growth hormone therapy. What do you think is the correct answer? And Nader is 6 years old. He has decreased growth velocity in the previous year, mid-parental height on the median, baseline investigations are normal, low ACTH and cortisol, low free T4 and normal TSH. He has central hypocorticism and hypothyroidism, which were corrected, but no catch-up growth, and MRI shows hypoplastic pituitary. What do you think? 1 growth hormone stimulation test is required for growth hormone deficiency, or 2 tests, or we just diagnose growth hormone deficiency and give growth hormone therapy? Actually, there are some cases or some conditions in which 1 growth hormone stimulation test is required for diagnosis of growth hormone deficiency. If there is defined CNS pathology, if there is history of irradiation, if there is genetic defect of growth hormone deficiency, or if there is multiple pituitary hormone deficiency. So not all cases require 2 growth hormone stimulation tests. There are other conditions in which growth hormone stimulation test is not required at all for the diagnosis of growth hormone deficiency. If the oxological criteria are positive, if there is major pituitary malformation or brain tumor or cranial irradiation, or if there is deficiency of at least 1 additional pituitary hormone. And also it is not required if it is a case of Turner syndrome, Noonan syndrome, Prader-Willi syndrome, SHOX gene deficiency, because all of these cases have growth hormone resistance rather than growth hormone deficiency. So no need for growth hormone testing in these indications on the slide. They have growth hormone resistance, so no need to provoke for growth hormone stimulation tests. And there are other conditions in which random growth hormone levels are enough. For example, in a neonate or an infant with hypoglycemia, hyperbilirubinemia, poor growth, low IGF-1, IGF binding protein 3, only the random growth hormone less than 7 is enough. So these are the answers as has been demonstrated in the previous slides. Then to treat or not treat, does every short child needs growth hormone therapy? Some pediatricians would say, let us try to give growth hormone therapy for 6 months and see if it works. Again, we have to balance the risks versus the benefits, because if we overdiagnose growth hormone therapy, if we overtreat by growth hormone therapy, this would be wasted expenditure and would be exposure to potential adverse effects of growth hormone therapy. And on the other side, if we underdiagnose and undertreatment, we get a short child at the end of the day. So we should always keep the balance, and we should always ensure safety of growth hormone therapy. And these are the side effects of growth hormone therapy, although they are very rare. But actually, we have always to search for them and to monitor the safety of children under growth hormone therapy. So always balance the risks versus the benefits, and always ensure accurate diagnosis and appropriate management of growth hormone therapy. Growth hormone therapy can be beneficial or cannot be beneficial. If beneficial, but who, what dose, why, when, and what are the precautions? who we have already mentioned the approved indications of growth hormone therapy. What is that? Different indications have different doses of growth hormone therapy. And when we suspect growth hormone resistance, the doses are usually higher than when there is growth hormone deficiency. And these are the indications, and these are the benefits of the growth hormone therapy. We want that this short child lead to catch-up growth to the child's genetic potential, to maintain his growth channel, to reach puberty at normal timing and normal intensity, and to reach adulthood in an acceptable final adult height with a normal body composition and a normal physical and mental energy. And these are real case scenarios of a child with growth hormone deficiency who received growth hormone therapy at a dose of 25 micro-kg per day, and see how he improved, how he catch up growth, how he maintained his growth, how he reached puberty and reached his final adult height at the end. And these are other scenarios like Hassan, 14 years old, who started puberty at the age of 12 and then got pubertal arrest, did not achieve growth spurt, bad growth velocity in the past 6 months. He had headache, decreased vision, squint, worsening of school performance, frequent syncope with hypotension. And then the diagnosis was craniopharyngioma. And as we mentioned, growth hormone stimulation test is not required. And on the contrary, it is hazardous to be done. But we have always to remember that when there is multiple pituitary hormone deficiencies, we should always correct the hormonal replacement therapy, starting cortisol replacement and thyroid replacement, then growth hormone therapy. Okay? So growth hormone therapy in the transition period, as we said, that we sometimes continue growth hormone therapy even after completion of the final adult height in order to benefit of the metabolic functions of growth hormone therapy. Chronic diseases, this is a child with chronic renal insufficiency who benefits from growth hormone therapy. And remember the growth chart, when the height is affected and the weight is affected, always suspect the presence of a chronic disease. But if the height is only affected and the weight is not, always think of the endocrinal disease. This child had chronic kidney disease and received growth hormone therapy in a dose of 45 micro-kg per day and really improved. But we should always remember that we should correct the CKD-related limiting factor first before going to the growth hormone therapy. And the small for gestational age is also an important indication, but we have to wait at first for the catch-up growth from 2 to 4 years. If the child does not catch up growth, this child may benefit of growth hormone therapy. Actually, 99% of children small for gestational age catch up growth, but the minority will still need growth hormone therapy in a high dose in order to reach their final adult height. So this is the correct answer. Wait for catch-up growth for 2 to 4 years. And always remember the long-term health risks in small for gestational age, the metabolic syndrome, the precocious puberty, the polycystic ovary syndrome. So the recommendations and the guidelines, the take-home message is that short stature has a rich variety of causes. Proper history, examination, anthropometry, baseline investigations are mandatory for the diagnosis. Growth hormone therapy is approved for many causes of short stature. Do growth hormone testing only when you suspect growth hormone deficiency. Growth hormone deficiency is a clinical diagnosis complemented by biochemical and radiological investigations. 2 provocative growth hormone tests should be done safely and appropriately in isolated growth hormone deficiency, but remember that there are certain indications when only 1 growth hormone test is needed, and there are other indications when no growth hormone testing at all is indicated. Remember, please, the approved indications of growth hormone therapy, and remember that the dose differs according to the cause. We should start growth hormone therapy as soon as the diagnosis is made and give the appropriate dose and monitor the child for effectiveness as well as the safety. Don't forget to compensate for multiple pituitary hormone deficiencies in the correct order if they are present. And don't forget to continue growth hormone therapy in the transition period in cases with severe growth hormone deficiency, multiple pituitary hormone deficiency, CNS tumors, severe hypothalamo-pituitary structural defects. We should always balance the risk-benefit ratio in growth hormone therapy to increase the effectiveness, to ensure the safety, to judge the cost effectiveness, to provide a better quality of care, and always to ensure the adherence and the compliance. And at the end, an integrated care between the pediatricians and the pediatric endocrinologists is very important for early referral from the pediatrician to the pediatric endocrinologist for better outcomes under growth hormone therapy. Thank you very much, and let us work together for optimum growth for all children.